Make this a little bit smaller for you guys. All right. All right. We're going to start it off pretty easy here, okay? But Mandy, if you can, there should be an option for the specific superfan emotes there. All right. Let's see. Now, do y'all want music or no? Because there was a couple people who said that the music was distracting. So if you do want, Christina says no, Dream says no. Okay, all right. Yeah, a couple more yes or no's. No music. Okay, all right. Didn't realize I was offending so many people. All right. All good. All right. Mary was a fan of the music. That's okay. All right. Thank you guys for the follows. I know. We were just grooving more than thinking. All right. I feel you. I feel you. Oh, Mandy. I don't know if that's it. Mandy's 44 years old. No, that wasn't one of the ones that I had put in there, Mandy. They're actually like different letter icons. So I'm not exactly sure what that looks like on your end, but they're okay. But yes, guys, answer here is going to be A. Answer here is going to be A. So here we're talking about metabolic alkalosis. Okay. So we have metabolic alkalosis with vomiting and loop diuretics. So this strongly predicts that there's going to be some sort of potassium issue. So we need to keep an eye on that for sure when we have our patients on those diuretics like furosemide, right? Okay, and the telemetry showing PVCs. Although when your potassium is lower, yeah, I guess you would see some PVCs, but Caitlin, stop spamming my live, please. Okay. With low potassium, you'll see like U waves and things like that. All right, but could likely see PVCs as well. All right, so now that we have our brains warmed up, let's go to question 2. Little select all that apply. Let's go. All right. I'm studying for the T's. I might as well do. No, stay with us. Stay with us. You might learn something. Let's go. All right, guys. A post-op client receiving NG suction. Some warm up, bro. What? Okay. They become confused, have a seizure. Here's their labs, okay? They're on some hypertonic saline started through a central line. Which findings require the nurse to immediately slow and stop the correction and notify the provider? All right, what are we thinking here? Okay, seeing a bunch of different answers. All right. I see a lot of B, C, and E. Okay. Would like an explanation on C2. Sure, we'll go through the rationale here. All right. All right, so the answer for this one, guys, is going to be A, B, and E. Okay? A, B, and E. So let's go through those kind of in that order for A. All right. Let's see. Let's read the question one more time. Which findings require the nurse to immediately slow or stop the correction and notify the provider? Okay, so I just want to make sure you guys read the question thoroughly. All right, so serum sodium rise from 116 to 122 in 2 hours. That's kind of a big deal. Okay, that we would consider that a rapid rise for 2 hours. So it risks osmotic demyelination. Osmotic demyelination. So correction has got to be tightly controlled. So A is one of the things that we would need to slow or stop and notify the provider, right? B, new bulbar symptoms like dysarthria or dysphagia, okay, after initial improvement can signal demyelination, all right? And then E, okay, hypertonic saline can cause volume overload or some pulmonary edema. So anything that indicates that there might be new crackles or wheezing with increased work of breathing is urgent, all right? So A, B, and E are the things that we would need to address and report, okay? So let's look at C. Some people said sudden severe headache with bradycardia. All right, so headache with bradycardia suggests increased ICP, okay? This is important, but it's not the most specific trigger to slow sodium correction compared with overcorrection signs, okay, listed in A, okay? For D, rising urine output may occur, okay, as the ADH effect changes. So it's a watch item, but not an automatic like stop by itself. All right, and then for F, I don't think anybody picked F, but +2 milliequivalents a liter in 2 hours is generally within kind of that cautious correction ranges. All right, typically follow your facility protocol. Okay. All right. I mean, let's see. What do you guys think? Yeah, A, B, and E is the answer. You could make an argument for C, but this is more specific to the specific trigger of the sodium issues. Okay, not the ICP issue. All right, guys. Let's keep it moving just a little bit. I don't want to get too bogged down here. Okay. All right. So a client, if there's anything you guys are curious about, either you can send me a DM or jot it down on a piece of paper. Go ahead and look that up after the fact. Okay. All right. So a client with diabetic ketoacidosis is on an insulin infusion. The anion gap is improving and glucose is 240 after several hours. Okay. The client suddenly reports tingling, muscle cramps, and palpitations. Telemetry shows U waves. Which action is the priority? Which action is the priority here? Question number 3. All right. And guys, throughout these lives, I'll pop up the link for registering to be a super fan at the bottom of the link. Again, moving forward, as discussed earlier, the Tuesdays and Thursdays lives starting next week are going to be for super fans only, okay? If you're just jumping in, that might be news to you. Happy to talk about it a little bit later, okay? It'll be Sundays lives are for everybody. Tuesdays, Thursdays are for super fans, okay? All right. So question 3, let's go through it. Thank you guys for the follows. All right, it is going to be B. All right, it will absolutely be B. Assess potassium level immediately and replace per protocol. Why? Because when we see U waves plus things like cramps and paresthesias and palpitations, all those things point to hypokalemia. All right, which insulin can lower by shifting that potassium back into the cells, okay? So we need to assess the potassium and replace it. Would you also do C? Okay, no. Calcium stabilizes hyperkalemia-related membrane activity, okay? It doesn't fix the hypokalemia, but good question. All right. That's definitely there to be a trap. All right. A client with CKD has a potassium of 6.8 And ECG shows PT waves and QRS widening. Orders include insulin, dextrose, nebulized albuterol, calcium gluconate, and sodium zirconium cyclosilicate. Okay, which intervention most immediately reduces the risk of ventricular fibrillation? Here we go. Here's your question to that last one. All right. Didn't realize these were back to back. All right, C, and then there was a D that popped in there. Okay. All right. Good job, guys. Good job. All right, so the majority of you, I think, got this. So the answer is going to be C. All right, it's going to be C, that calcium gluconate, because what does the C do? What does calcium gluconate do? It stabilizes the cardiac membranes. All right, and it does it quickly. So thereby it reduces any immediate dysrhythmia risk, okay, while the other potassium lowering therapies take effect. All right, awesome. Thank you guys for all those follows. Much appreciated. All right, let's go to 5. All right, a client with tumor lysis syndrome is started on rasburicase. Okay, shortly after, the client becomes short of breath, appears gray, and the pulse ox reads 85% despite high flow oxygen, but the ABG shows a PaO2 of 240. Which action is the priority? That's a mouthful. All right. Okay. Thank you, Casey Matt, for sharing the live. Thank you guys for always liking the live there too. All right. Question 5. What are you guys thinking? I'm seeing B, A. What else? Anything else? Farrah says B. Imbalances says A. Jen says B. So you guys are basically between A and B. Okay. All right. Well, for those of you that are Team B, you are correct. All right. So Team B wins the day here. So we are going to obtain, the low SpO2 with the high PaO2 suggests that there is some bear with me here. This is a mouthful. Okay, dyshemoglobinemia. Okay, rather than any sort of true hypoxia. I don't know if I can put that in the chat per protocol being the. I can't. I don't have great access to my chat function to be able to comment on here. Okay, so dyshemoglobinemia, all right, or in if you want to in parentheses, I'll spell it out so that it's easier to spell than it is to say. So methemogloblin, okay. So this isn't true hypoxemia. So the rasburicase can precipitate this in susceptible patients. So the co-oximetry confirms that oh my God, I can't. So the word I just spelled, right? And then that guides the therapy. That guides the therapy moving forward. Okay. Holy moly, that was a mouthful. Farrah, yes. All right. Here we go, guys. Question number 6. All right. A client with chronic alcoholism is started on TPN after being NPO for a week. Within 24 hours, they develop weakness and shallow breathing. Labs are as follows. Which actions are appropriate now? Select all that apply. Which actions are appropriate now? Select all that apply. What are you thinking? All right. Yeah, I know there's a lot of reading there. All right, Mary, first one to jump in here with A, E, and F. Okay. Lots going on here. All right. So the question and the stem of the question here does spell out a specific type of syndrome. Like all those things together kind of have a name. All right. Does anybody know what that syndrome is called? Something it's very specific to the TPN. Okay. Jennifer got it. That's right. It's called refeeding syndrome. All right. Jennifer gets A's. Okay, guys. Jennifer's that nursing that girl in your class that it's like, I don't even know how I got an A on that test. I barely even studied. I'm just kidding, Jennifer. Much love. Thank you guys for the follows. All right, so the answer here, guys, is going to be A, B, C, and E. All right, A, B, C, and E. So again, the question was, which actions are appropriate now? So let's look at A, B, C, and E. Those are the correct answers. So this is refeeding syndrome. So it's characterized by severe hypophosphatemia, all right, with low potassium or magnesium after nutrition restart. Okay, so the phosphate repletion is urgent because low phosphate, somebody dropped the normal phosphate level in the chat, okay, because low phosphate can cause respiratory failure and weakness. All right, and then for C, all right, magnesium repletion is needed because to correct hypokalemia effectively. So magnesium repletion is needed to correct hypokalemia effectively and reduce arrhythmia risk. All right, and then for E, telemetry is going to be appropriate because there's multiple electrolyte dysrhythmia risks here. For those of you who maybe threw D in there, all right, calcium gluconate does not raise your phosphate level. All right, calcium can worsen that calcium phosphate precipitation issues. And then for F, increasing dextrose can worsen electrolyte shifts. All right, for the normal levels, phosphate is about usually 2.5 to 4.5. So our phos is 1.2. So we need to recognize that as being low. On the NCLEX, though, they should give you the normal ranges within the question somewhere. All right, so you'll be able to tell that that's low, but you still need to understand what the symptoms are. Okay? All right, so a lot going on in that question, but if you got a piece of paper beside you, jot down refeeding syndrome. All right, and just review that when you have time. Okay. All right. 7. All right. A client treated for SI-ADH has a sodium of 122 and is on fluid restriction. The provider orders demeclocycline. Which teaching points should the nurse include? Which teaching points should the nurse include? Thank you for sharing the live. where can you see these types of questions? Well, this is an AI that I trained to create and generate NCLEX questions. So you won't find these specific questions anywhere else but here. All right. Select all that apply. Which teaching points should the nurse include? Okay. And for your reference, if you're jotting this down, demeclocycline is a tetracycline antibiotic used to treat like bacterial infections like pneumonia, acne, all right, and then it has an off-label use for use with SI-ADH. Okay? Okay. Let's look at these teachings. All right, for those of you who put A, B, and E, you are correct. Alpha, Bravo, Echo. All right, so demeclocycline can cause photosensitivity. It can be nephrotoxic, all right, especially in older adults or those with kidney disease. So we need to monitor kidney function. All right, and then in E, right, so we know sodium correction has to be gradual. So adherence to restriction and lab follow-up is key. All right, so A, B, and E. That's right, Farrah. Hell yeah. All right, so let's look at the other one. So for C, calcium can impair absorption of these types of medications. Then D, correction is not immediate and overly rapid correction is dangerous. And then for F, somebody asked about F. So contraception interaction is more typical with certain enzyme inducers, not the key safety teaching here. Okay? All right. So there you have it. Let's go to 8. All right, a client with hypocalcemia has perioral tingling and carpopedal spasm. They ordered IV calcium gluconate. During the infusion, the client complains of burning at the IV site and the skin blanches. What is the priority action? What is the priority action? Thank you guys for all the follows. Drop your answer down below. Let's look. Okay, seeing lots of B's coming in. Let's see. Anybody else? All right, awesome. Thank you guys for those follows. Let's look at the answer for question 8. And if you said B, you are correct. All right, calcium salts are vesicants. They're irritants. All right, so blanching and burning suggests that there's some sort of infiltration or extravasation. So that requires that you do something about it immediately because we're basically causing tissue damage, and we need to limit that, okay? We need to limit that crap. All right, so I don't know that anybody really answered anything but B that I saw, so we'll keep it moving here. All right, question 9. Thank you guys for sharing the live, who are joining, and thank you guys for following. All right, a client with prolonged QT is being treated for torsade de pointe and is ordered IV magnesium sulfate before administration. Which findings make magnesium administration highest risk and require immediate follow-up? All right. Thank you guys for those gifts. That's awesome. I appreciate that. Heart me, Timmy Noel. All right. And then for those of you, while you guys answer this, again, this week's live, Sunday, Tuesday, Thursday, are for everybody, okay? And that's the way they've been for the last 4 months. But I'm moving towards a super fan model for my lives on Tuesdays and Thursdays. So Sundays you'll still be able to join, but Tuesdays and Thursdays lives will be for super fans only. Okay. You can become a super fan by hitting the link down below. All right. It's $10 for the month. All right. Basically $1.15 or something per live. So you get 8 hours of time with me for $10. All right. So would be grateful if you guys would consider that, but that's kind of how I've justified keeping these going, because they are a lot of work. They're a lot of work to prepare for, and I know that you guys get some benefit out of it. So I gotta value my time as well. I love doing this for you guys. All right. All right. So question 9 here. A and B are correct, and then it looks like y'all are between D and E. All right. Well, let's look at it. So the correct answer here is going to be A, B, and D. All right. Mandy got it. Mandy got it. All right. Miss M also got it. Fantastic, guys. So A, B, and D. All right, because magnesium can turn you to mush, mush, right? So magnesium can depress respirations, neuromuscular function, respirations, right? All that stuff goes down. Absent deep tendon reflexes. All right. So you need to clarify before you give more. All right. Good job, nature. And then renal impairment increases when renal impairment increases the magnesium accumulation risk. All right. Because magnesium is in fact renally cleared. All right. So A, B, and D were the correct answers there. All right, so good job, guys. A, B, and D, correct answers. Fantastic. Let's go to 10. All right, a client with severe constipation has been taking magnesium-containing laxatives daily. They now have lethargy, facial flushing, hypotension, and a new PR interval prolongation on ECG. Which lab result best explains the presentation? Which lab result best explains the presentation? PR interval prolongation. Okay. I'm going to take all right. So, guys, if you answered B, you should write this one down because you did not get it correct. Okay? So, PR interval prolongation is not something you see with potassium issues. Timmy Noel just became a super fan. Got to shout you out. Thank you, Timmy. Thank you so much. All right, appreciate that. I'll see you next Tuesday and Thursday for sure. All right, so low potassium, typically you'll see U waves, okay? And then for hyperkalemia, you're going to see peaked T waves. All right, but PR, prolongation, that's the initial part of your PR, and then you have your QST. All right, so that's the front part of your QRS complex. So that is going to be related to A, your magnesium. Okay, your magnesium. Magnesium's normal level is what, 1.7 to 2.2, something like that. All right, so when you have an elevated magnesium, you're going to see that increased PR interval. So hypermagnesemia, write this down, guys. Hypermagnesemia, all right, causes flushing, hypotension, lethargy, and conduction delays, which cause the PR prolongation. All right. Megan, thank you for the heart me. I appreciate that. All right. So, magnesium laxatives can accumulate, okay, especially with decreased renal clearance. All right. So, hypermagnesemia causes conduction delays, which in turn you have the flushing, the hypotension, the lethargy. All right. So jot that down. Yes, it is A, guys. It is A. All right. You're like, is it not A? No, the answer is A. All right. And again, potassium, low potassium, usually you have U waves. High potassium, you have peak T waves or wide QRS, PVCs, things like that for potassium issues. All right. Good job. All right. This is 11. Disregard that there's no number. All right, a client with metastatic cancer reports new constipation, intense thirst, and foggy thinking over 2 days. Okay, telemetry shows a shortened QT interval, and the client is taking calcium carbonate PRN for heartburn. Which lab value would best confirm the likely electrolyte imbalance? All right. All right. I've seen A, B, and C so far. Okay. All right. So here we go, guys. Let's look at question 11. Yeah, the answer here is going to be B. All right. Again, so that potassium, we know that potassium level is high. We're not going to see any shortened QT interval. If anything, with potassium, it would be longer. Okay. So for an elevated calcium level, we have hypercalcemia. We're going to see things like constipation, polydipsia, confusion, and shortened QT interval. Those are all classic hypercalcemia symptoms. So when we have malignancy plus calcium-containing antacids, that increases the risk of an elevated calcium level. All right. So B is our answer there. And just to recap, A, the hyperkalemia, again, often causes peak T waves, widened QRSs, not shortened QTs. All right, then for C, hypernatremia, you got to think brain issues. So that's neuro changes, okay, and thirst, but it doesn't explain the shortened QT and constipation. The D, hypomagnesemia, is associated with prolonged QT or torsades risk and neuromuscular irritability, not a shortened QT. All right. There we go. Thank you guys for the follows there. Let's jump to question 12 here. All right. A client after thyroid surgery reports tingling around the mouth and hands cramping up. All right. You notice the carpopedal spasm and a high-pitched inspiratory sound when the client is anxious. Which findings are most consistent with hypocalcemia? All right. I like this one. Which findings are most consistent with hypocalcemia? All right, if you were paying attention to the couple questions, we should have some of the answers here, guys. All right. All right, we'll get a few more answers in the chat here. And then we will go over this. Okay, Nick, he says A, B, D, and E. All right, I'm looking for the correct answer. Jennifer's saying A, B, C, D, E. Megan says A, B, D, E. Yep, okay, if You answered A, B, D, and E. You are correct. All right, A, B, D, and E. So, definitely. So the perioral tingling, that's an early neuromuscular irritability sign of hypocalcemia. All right. Then, yep, you were one off. That's all right. B, the Schwarzschild sign reflects increased neuromuscular excitability. All right. Then D, hypocalcemia commonly prolongs QT, having an arrhythmia risk, right? Because remember, in the last question, the hypercalcemia shortens the QT, all right? So hypocalcemia prolongs the QT. All right, and then for E, tetany. Tetany and cramps occur due to increased neuronal excitability, okay? The other answers that were wrong were C and F, right? Because constipation is more prevalent in hypercalcemia. And then peak T waves are more consistent with hyperkalemia. All right? So, hopefully you're getting that. Again, I'm going to post this whole live over on my YT under Nurse Jimmy Official. So you'll be able to watch this back if you guys are getting stuck on a question or need to hear me say it again. Okay? But also keep a piece of paper or notebook at your side so that you can jot down some concepts that you want to go back to and look up later, maybe after we're done. Okay? All right, Shana, yep. While you guys answer this, I am live Sunday, Tuesday, Thursday. Tia Nicole, I passed my... Guys, drop some love for Tia. You got to drop some love for Tia right now before you even answer here. All right. Tia has been on here, I know, for a while. So, awesome job. Super proud of you. That's amazing. Love, love, love. Daddy Dart, I'm just a super fan when I get my money. I hear you, brother. I hear you. I'm living. And, yep, I got you, man. All right. So, somebody asked how frequently I'm on here Sundays, Tuesday, Thursdays. So for those of you who are maybe just cycling in the last 15, 20 minutes, I go live Sunday, Tuesday, Thursday. Sundays are still going to be for everybody. Okay, Sundays lives, everybody can join. But starting next week, on Tuesdays and Thursdays, they are going to be for super fans only. Okay, they'll be for super fans only. I'm going to pin it here for a few seconds here. So it's $10 for the month. Okay, so that's 8 hours of time with me, a little over $1 per live. All right, so you get a lives Tuesday and Thursday. There'll be smaller groups. There will only be a couple of us probably in here. All right. And super fans get to pick the topics that we cover the following week, all right, in a separate space where you have pretty much direct access to me, okay? So consider that if you're interested in picking the topics for the week's lives, that could be motivation as well. All right, so question 13, the answer here is going to be D, delta. All right, so the question is, which action is the priority? The answer is replace the magnesium as ordered. Continue close monitoring. So let's look at it. So low magnesium can what? It can also trigger dysrhythmias and worsen digoxin toxicity even when the potassium is near normal. Okay, believe that. All right, so correcting the mag improves electrical stability, all right, and helps prevent any recurring ventricular ectopy. Okay? Are the NCLEX questions the same for LPN and RN? I mean, LPNs, you're not going to really be dealing with unstable patients. Like, questions more so on the RN will be. All right? But there'll be a lot of delegation, leadership, things like that. Okay, so If anybody put A, no. All right, so for A, that treats hyperkalemia. Okay, nothing suggests that there's an elevated K right now. For B, calcium is used for ECG, unstable hyperkalemia and hypocalcemia symptoms. Okay, it doesn't address the hypomagnesemia-driven digoxin toxicity. Okay. All right. And let's see. And then for C, no hypoglycemia pattern is provided here. So we have the visual changes plus the ectopy fit that there's a digoxin toxicity risk. Okay. What'd you say? What's the mag level? It's the normal level's around like 1.7 to 2.2. All right. All right. Fantastic, guys. Thank you for the roses. Yip, yip, yip. Awesome job. Great job, guys. All right, let's go to 14 here. A client with chronic kidney disease missed dialysis and says their legs feel heavy and feel chest fluttering. Which findings are most consistent with hyperkalemia? All right. Again, hyperkalemia, guys. We need to get this down. All right. Ooh. Mary's saying A, B, D, and F. Okay. All right. Christelle says A, B, and D. Megan says A, B, D, and F. Fatma says A, B, E, and F. Okay. All right. Thank you guys for the follows. All right. So correct answer here is in fact A, B, D, and F. A, B, D, and F. All right. So we're looking for signs and symptoms. Hyperkalemia, high potassium, anything above 5.0. Peak T waves, classic early ECG change. Peak T waves. All right. Hyperkalemia commonly causes weakness and heaviness. Weakness and heaviness. And then QRS widening suggests worsening electrical conduction delay. So it'll start with the peak T waves, and then that peak T waves starts to get gradually wider, and then, oh shit, we have VFib. And then we have a wide QRS that is unorganized. All right, and then they're dead. So you need to address it. Yep. All right, and then for F, okay, you have the sine wave or bradycardia. That is a late pre-arrest hyperkalemia pattern. Somebody said, why not E? Okay, so why not peri-tingling and tetany? Those point towards hypocalcemia. So guys, if you see things like muscles, okay, calcium has a lot to do with muscles. So if you see things like tetany, okay, perioral tingling, things that have to do with muscles and things like that. Calcium is it's a common culprit. All right, hypokalemia. They have some other symptoms. A lot of cardiac stuff there, obviously, but they can cause weakness, heaviness. All right, sometimes some muscle cramps. All right, but usually when you see potassium issues on the NCLEX, they will be talking about safety stuff. Can you identify a lethal arrhythmia, right? All right, for the ECG changes on hypokalemia, you're going to see like U waves. Okay, U waves are most common with hypokalemia. Okay. All right. Good questions. Let's go to 15. We got time for a couple more. All right. A client on carbamazepine presents with new confusion, severe headache, and nausea. Vitals are stable, lungs are clear, and the family reports the client's been drinking a ton of water for a week. Which lab result best matches the likely cause of these symptoms? All right. All right. Yes. Good job, guys. Good job. Yep. Answer here is A, sodium. So we know our normal sodium is about what, 135 to 145. So carbamazepine, it can contribute to SIADH, which then leads to hyponatremia, which can then cause headache, nausea, confusion, and seizures. Okay? So yeah, sodium of 118, critically low and fits the neuro symptoms. So sodium is the electrolyte where you think, okay, sodium correlates to the brain. Okay, calcium is to the muscles, right? Potassium is to the heart. Okay. All right. So I've got a couple videos on electrolytes. There's a whole NCLEX review playlist where you guys can check that out. There's 33 parts to that playlist. All right, let's skip forward a little bit. Let's go into the 20s here. Let's see. All right. Let's look at 20. Let me see. 20, that's 19. There's 20. All right. A client with hyperkalemia and metabolic acidosis is ordered IV sodium bicarb as part of treatment. Which client is at the highest risk for harm from bicarbonate therapy? Some Mrs. M. No, my NCLEX playlist I have here on TikTok. It's 33 parts. It's a full review of short NCLEX videos. But on my YT, I post these recordings. All right, the full length recordings of these are over there under Nurse Jimmy Official. All right. Absolutely, Shanna. Absolutely, Miss M. All right. Jasmine, I'm kind of new. Do you help determine if someone's ready to take the test? I don't determine if anyone's ready to take the test. If you're trying to test or you're about to take the test in a couple of weeks, I do also create custom study plans for you guys. All right, so if you're interested in a custom NCLEX study plan to take the guesswork out of what to study each day, let me know, okay? JoJo, everybody drop some good vibes and love for JoJo taking their NCLEX tomorrow. All right. So I'll go over how to get the custom NCLEX study plan here, probably after this question or the next, okay? All right. So question 20 here. There's a little bit going on. All right. So correct answer here is going to be D. All right, is going to be D. All right, because sodium bicarbonate adds a sodium load, all right, and can worsen volume overload and pulmonary edema, especially with heart failure and crackles. All right, does that make sense? All right, so sodium bicarb still has sodium in it. So if you have issues like represented in D, with decompensated heart failure and crackles, yeah, this is not a good med for you. So if you've got some existing hypernatremia at 149, that's definitely going to increase the risk of worsening sodium, right? You've got some osmolality problems going on. So yeah, hell yeah, D is definitely what we need to look out for. All right. Let's find one more select all that apply here, guys. Let's go out with a bang here. Ooh, baby. Ooh, baby, I love the way. Okay, here we go. Let's go to... No, I think that one's really hard. There was one that I thought that was similar. Okay, this is basically... Oh, yeah, 29 is the shiz. Oh, you guys are going to love 29. Okay. This is basically a culmination of this live. All right. So let's do it. Let's get in it right now. Okay. All right. Let's go. Mandy, don't even worry about it. I don't know what you just think you saw, but... All right. Mandy, it's okay. Don't worry. Don't worry. Let's go. Select all that apply. Keeks, don't put a question mark after it. Say it with your whole chest, okay? Be confident. Be confident, all right? Let's do it. These are just inverse of the, all right? Basically. All right. Yes, of course, Mary. All right, guys, let me pop this up just a little bit higher so you can see my pretty face. Okay. All right, so those are not A, B, not sure about the rest. A, B, C, that's all I know. Okay, so answer here is going to be A, B, D, and E. A, B, D, E. Okay, baddie. Okay, you can. Are you a baddie? Stop it! Stop it! Just shut up, Jimmy. You're being dumb. Okay, so A, B, D, and E. Let's look through it. Okay, so A, hypokalemia. We know that there are hypokalemia and hyperkalemia. One has U waves, one has PT waves, right? So A, hypokalemia does cause U waves and ST changes. Okay? So, great. Hypokalemia, A, check. B, hyperkalemia. PT waves, widening QRS. If you've been paying attention at all, you should have gotten B. Okay? Because hyperkalemia, that's the risk. PT waves that then develop to widening QRS, which goes to VFib, right? Yeah, good job, Megan. Had me guessing myself bad. I feel you. All right, C, hypocalcemia. All right, hypocalcemia does what? No, it typically prolongs the QT interval. Okay, hypercalcemia, okay, excites things. Okay, it's excited. Okay, it shortens that QT interval. All right, so A, B, D are so far the correct answers. And then E, okay? E is hypomagnesemia. All right, that increases your risk of torsades. So often with some QT prolongation. All right, then F, hypernatremia. All right, no. Hypernatremia, that gives you neurosymptoms, right? Because sodium can mess with your brain, can dehydrate your brain, things like that, okay? It does neurosymptoms, not so much ECG changes. All right. Okay. So, what was that? Was there, thanks for these reviews. Neurodivergent. What can we see with hypermagnesemia? Basically, hypermagnesemia, again, when you have increased mag, you have mag turns you to mush. All right. So everything's going to kind of slow down a little bit. Okay. So you're going to have a prolonged, it causes conduction delays. So you have a prolonged PR. Okay. In QRS intervals. Sometimes you see a widened QRS complex, elevated or peak T waves, bradycardia. Again, usually when you see things on the NCLEX related to hypermagnesemia, it might be a maternity question because they're preeclamptic, but you need to recognize the signs of magnesium toxicity, decreased deep tendon reflexes, decreased respirations, all right, decreased level of consciousness, bradycardia. It slows everything down. Okay? Yes, Megan, thank you. Hell yeah, love it. Let's get them in here. All right, so for those of you, again, real quick, if you guys are, a couple things. For those of you still in here, I'll be doing these lives. I do them 3 times a week, Sunday, Tuesday, Thursday. That's the way it's been for since October and November. All right, to make the most of my time, because this is time away from my family. It's time that I prep for these even after a 12-hour shift. Okay, I'm moving towards a superfan model, so Sundays will still be for everybody. But starting next week, Tuesdays and Thursdays are for superfans only. To become a superfan, you can hit this link right at the bottom, right here. All right, superfans only, Tuesdays and Thursdays. It's $10 for the month. It's a little like $1 something per live for 8 hours of my time. It'll be much smaller groups, and you get to help pick the topics for the following week. So even if you're in nursing school, okay, and you want a topic review because, hey, you got a cardiac exam next week, this is, we can do, if you want to vote and we do cardiac, we can do cardiac every damn week. Like, it's up to you. All right. So, let's see. Sorry. Yeah. And time away from my cat. Can you see my cat? Look how cute he is. Look how cute he is. All right. Yeah. That's time away from the kitty cat too. All right. So guys, go ahead and you can follow, wait, were you here today? You're talking about Maria? You're talking about me? I don't know what you mean. But also, guys, if you're interested, the other thing I do is custom NCLEX study plans. Some of you have them. Daddy Darv has one. Yeah, of course, Mrs. M. And a few others here in the chat do have custom NCLEX study plans. Guys, if you're interested in that, drop a me in the comment, M-E. All right, and we'll go over that real fast on how to order your own custom NCLEX study plan. Again, I try to keep these. Maria, the fans club starts next Tuesday and Thursday, okay? All right, I wanted to give everybody a week in notice. So starting next week, next Tuesday, Thursday. So this week is normal. All right, so let me flip the camera around. All right, this is my page. If you guys are interested, okay, in a custom NCLEX study plan, you go right here, all right, to the link in my bio. You click that. All right, that brings you to here. You click this first link, get a custom NCLEX study plan. All right, here's some testimonials here, people who've used the plan, who send me DMs, which I love receiving, telling me, hey guys, I passed my NCLEX. So you can check those out, but otherwise you just click this link, you fill out the form. It is custom to you, even if you're a repeat test taker. If you're not, that's fine too. Just click yes, this is your first time, or no. All right, and then I'm going to ask you just a couple of questions about your CPR that you should have. All right, look at that achievement. Mrs. M watched the live for 200 minutes. Fantastic. I appreciate you being here. So if you have taken the NCLEX before, I need that CPR info so I can make this as custom as possible to you, your test date. Okay, if you have access to any current subscriptions, pop that in there because I'm going to reference those in the plan. And if you know that you've got some weak areas that we need to address, let's focus on and build in some areas of focus. All right, not everyone's schedule is the same. Okay, so let me know how many hours you have available each weekday that you have to study, and also each weekend. And then let me know the days of the week that you are able to study, okay? Because maybe you don't have Wednesdays and Thursdays and you just have Sunday, Monday, Tuesday, Friday, Saturday. That's fine. I'm going to tailor that plan to you and what days you have available. And then anything else that you find helpful for me to know, your learning style, things that you've tried in the past that don't work, okay? Let me know. All right, and then you just pay the $25 down here, and I get these back to you in 24 to 48 hours. Okay, so check that out. Here, I'll show you is the full NCLEX review. All right, the full NCLEX reviews right there. That's 33 parts. Check that out. All right, and then the other thing is the cheat sheets that are available. There's 230 pages of cheat sheets for free in the NCLEX Vault. All right, just your name, email. All right. Then click Access Now. It'll open up the page for that. And then after each content area, there's a 25 question quiz associated with that. So check that out, guys. That is totally free. All right. So that is what is going on here in the Nurse Jimmy world. All right. So we're going to be implementing the super fans starting next week. Again, if you're a super fan, you get to help pick the topic for the lives the following week. All right. So even if you're, in nursing school, you have an opportunity to pick a topic that you want to see covered every single week. All right. Oh no, Ellie, you missed the live. We went over electrolyte imbalances and the pharmacology related to electrolyte imbalances. All right, so a lot of stuff on all the electrolytes, all the important ones: potassium, magnesium, calcium, sodium. All right, a little bit on phosphate. So, absolutely, I'm going to be posting this live over on my YT, okay, under Nurse Jimmy Official. You can go over there, check out all of the most recent lives. I've got a little bit of catching up to do. There's like 3 I haven't posted, but I'll get those put up tomorrow. Okay, so with that, go ahead and follow, guys, if you haven't already followed. And then also you can go ahead and become a super fan now so that you're locked in for next lives on next week's Tuesday and Thursday, because those lives will only be for super fans. Okay, so small groups, you get to help pick the topics. All right, but you need to join now so that you have access to the subspace that allows you to vote on the topics. All right, so go ahead and do that now. It's $10 for the month, and then basically a little over $1 per live. So 8 hours of time with me doing these review sessions for $10. Okay, cheapest tutor you're going to find. All right, so that being said, I am probably going to be peacing out here in a second. Give you guys a couple more seconds to follow if you're new here. All right, so that is pretty much it. All right, guys, I'm going to head off. I'm going to check my DMs here. All right, and until then, I'll see you guys Thursday. The topic Thursday, I believe, is infection control and related antibiotics. All right, so come back, check that out, and we'll get at it. All right, until then, guys, I'm Nurse Jimmy.